Hi everybody, and welcome to our module on transplants. The most common organ transplant in the United States is a kidney transplant. There's about 17,000 of those done per year, and the reason kidneys are the most commonly transplanted organ is because you can donate one and keep the other one and still have a functioning renal system. All these other organs here require the patient to die in order to be able to donate them, and thus there are far fewer donors and far fewer transplant operations. And usually the indication for an organ transplant is when the organ has failed. So if your kidneys aren't working anymore, you can receive a donated one to try and reconstitute your renal system. Bone marrow transplants are a special type of transplant procedure. There are about 17,000 of these done each year in the United States. And in order to transplant bone marrow into a recipient, you must first abolish their own bone marrow with very high dosages of chemotherapy. So patients who are undergoing bone marrow transplant are admitted to specialized units in the hospital called bone marrow transplant units. They receive very high dosages of chemotherapy, which will destroy their own bone marrow and all their cell lines. Then you reconstitute the cell lines with donor marrow. Now, sometimes the donor and recipient are the same person, so you take out some bone marrow cells, then you destroy the bone marrow with high-dose chemotherapy. This is usually done for cancers, and then you replenish the bone marrow with the cells from the same person who donated them. Other times the donor is a different person than the recipient, and then you are reconstituting the cell lines with the donor marrow. And one thing that's kind of cool and interesting about doing a donation from a different person than the recipient is the blood type can actually change because you are altering the bone marrow cells that create the red blood cells. So what are the reasons that people undergo a bone marrow transplant? Well, malignancy is one of the most common. So people who have leukemia or lymphoma often have to undergo a bone marrow transplant in an attempt for cure. In addition to lymphomas and leukemias, these are sometimes done for inherited red cell disorders. So pure red cell aplasia and sickle cell disease and beta thalassemia are sometimes treated with a bone marrow transplant. You can also do a bone marrow transplant in people who have had failure of their own bone marrow. For example, if they have aplastic anemia or Fanconi anemia. There are some metabolic disorders like adrenoleukodystrophy and Gaucher's disease, which can be treated with bone marrow transplants. And then there are very rare inherited immune deficiency disorders like severe combined immunodeficiency and Wiskott-Aldrich, and these are sometimes treated with bone marrow transplants. In order to talk about transplants, you need to know a little bit of transplant vocabulary. So when we say someone received an autograft, we mean that the donor and the recipient were the same person, and this commonly occurs in bone marrow transplants. So you take the bone marrow out of patient A, and then you administer very high dosages of chemotherapy to kill off their bone marrow that's remaining and any leukemia or lymphoma cells, and then you reintroduce the bone marrow into the same person who donated it. A syngenetic graft is a donated organ or bone marrow that comes from an identical twin. A xenograft is donated tissue from different species. So for example, some heart valves are pig valves taken from the pericardium of a pig, and that's an example of a xenograft. The graft comes from a different species. And then most organ transplants are what we call allografts. This is when you transplant organs between people of the same species. So for example, if you take the kidney from a human being and transplant it into another human being, that is an example of an allograft. Let's talk about the concept of matching. When you transplant bone marrow or an organ from one patient to another, your goal is to match the transplanted tissue. This means that the recipient's tissues and the donor's tissues should be the same or similar. If you don't match, this can lead to rejection of the transplant. The immune system of the recipient patient will attack the transplanted tissue as foreign, and you don't want this to happen because then your transplant procedure won't be a success. Let's talk about the features of a good match. And in order to understand this, let's suppose that patient A wants to donate a kidney to patient B. And in order for this transplant to be a success, we don't want patient B's white blood cells, their B and T cells, to recognize the kidney as foreign and to initiate an immune response. So how are we going to ensure that there is a good match between patient A and B? Well, first, we want them to have the same blood type. Secondly, we want them to have the same or very close MHC1 and MHC2 molecules. To understand this, let's look at these pictures I've drawn down here at the bottom. As you know, antigen-presenting cells in any patient will present self-antigens in the context of self-MHC. So when you have a self-antigen in the context of self-MHC, T cells will completely ignore this. They will recognize this as self and they will not initiate an immune response. If a donor antigen-presenting cell presents self-antigen in the context of donor MHC, and if that donor MHC is significantly different from the self-MHC, then the T cell may recognize it as foreign and may initiate an immune response. So this is why we want the MHC molecules to match as closely as possible so that the T cells will ignore the donated tissue and treat it as self tissue. And then the final element of a good match is a negative cross-matching screen. So in a cross-matching screen, you test the donor cells against the recipient plasma, and this assures that there aren't antibodies present in the recipient's bloodstream that will attack the donor tissue. So let's talk in a little bit more detail about why it's so important to match those MHC molecules between donors and recipients. So the donor cells, whether they're kidney cells or heart cells or bone marrow cells, will express MHC class 1. Recall that MHC1 is expressed on most cells in the body. And if those MHC1 molecules are different from the recipients, then the CD8 cells in the recipient will react and attack the donated tissue. In addition, MHC class II is also often expressed on donated cells. Recall that MHC class II is mostly expressed on antigen-presenting cells like macrophages and dendritic cells, and some of those antigen-presenting cells may be carried along with the transplanted tissue. In addition, it turns out that many vascular endothelial cells express MHC class II as well, so for this reason, both the MHC1 from the donor and the MHC2 from the donor will be transplanted into the recipient, and if those molecules are very different from the recipients, then their T cells will react. So we don't actually talk about matching MHC1 or MHC2. Instead, we talk about matching human leukocyte antigens or HLAs. And these are the antigens that make up the class 1 and 2 molecules. So if these antigens are different between donors and recipients, then the immune system will classify the donor tissue as foreign and the transplant will be rejected. So in order to match the MHC molecules, you need to match the human leukocyte antigens. And in order to match the human leukocyte antigens, we need to look at genes on chromosome 6 that encode for the HLA antigens. And the genes on chromosome 6 determine what's called your HLA type. So there are 3 important HLA genes that code for MHC class 1, and they're called HLA-A, HLA-B, and HLA-C. There are a number of important genes that code for MHC class 2, and they are called HLA-DR and DM and DO and DP and DQ. They all start with the letter D and then have another letter after it. Each of these genes, HLA-A, HLA-B, HLA-DR, are highly polymorphic. This means there are many different HLA antigens found from person to person. For example, there are more than 50 known HLA-A subtypes found in human beings, and the subtypes are all numbered A1, A2, and A3. And if the donor and recipient do not match, you can potentially get rejection. So ideally, if your donor is HLA-A1, you want your recipient to be HLA-A1. And if your donor is HLA-B10, you want your recipient to be HLA-B10, and so forth. You should know that some of these HLA subtypes are associated with autoimmune diseases. For example, if you have the HLA-B27 subtype, you have a higher risk of developing ankylosing spondylitis. In addition, you also have a higher risk of getting psoriasis and inflammatory bowel disease and Reiter syndrome. And this is likely due to the fact that there is something about the makeup of the B27 antigen that triggers autoimmune diseases like these in certain people. In the case of A3, if you have the HLA-A3 subtype, you have a higher risk of hemochromatosis. And there are lots of these HLA associations with autoimmune diseases that you can read about and look up in books. So back to the concept of HLA matching for transplants, each patient receives 2 sets of HLA genes. All HLA genes are transferred en bloc from each parent. So for example, you may get one set from your mother that might be A2 and B3 and so on and so forth, and you get another set from your father that might be A4 and B7 and so on and so forth. This means that a sibling of yours has a 25% chance of being a perfect match to you in terms of the HLA antigens. Here's a picture to make that a little bit more clear. Let's suppose we have a patient who has a father with 2 sets of HLA genes. Let's call the first set the F1 set. It might be made up of the A2 subtype, the B4 subtype, and so on. The father then has a second set, which we'll call F2, made up of the A1 subtype and the B3 subtype, and so on. This patient's mother similarly has 2 sets of genes. We'll call them the M1 genes and the M2 genes. Now they're all transferred en bloc, so this means that the patient can receive one set from each parent. So let's suppose this patient received the F1 set from the father and the M2 set from the mother. This means a sibling has a 25% chance of also getting that F1 set or that M2 set. So they often ask you what the likelihood is of a sibling being a perfect match to a patient in terms of HLA antigens, and the answer is 25%. And it's because all these genes, even though there are many, many sets, are all transferred en bloc together from father and mother to offspring. There are three HLA genes that are most important for solid organ transplants like kidneys and hearts and livers, and those are the HLA-A genes, B genes, and the DR genes. And sometimes you'll hear it said that a patient is a 6 out of 6 match, and what they mean is that the donor and recipient completely match in their two sets of these three genes. Sometimes more genes are also tested like HLA-C and HLA-DQ, and then you can hear things like a 10 out of 10 match. It all depends on how many of these HLA subtypes are being tested. Bone marrow transplants have some unique issues with matching. Recall that in a bone marrow transplant, chemotherapy is administered to abolish the recipient's bone marrow. So the grafted cells have to replenish all cell lines, including the white blood cell lines like T cells and B cells. Bone marrow transplants are matched for numerous HLA antigens, including HLA-A, B, DR, and C, sometimes also DQ and P. And when you have a mismatch between donor and recipient in bone marrow transplants, you have two problems. First of all, the new cells can be rejected, and secondly, you can have something called graft versus host disease. So graft versus host disease is mostly a complication of bone marrow transplants, although it is reported sometimes in solid organ transplants. And what happens here is that the donated or grafted T cells, especially the CD8 T cells, react to the recipient cells. So the donated cells see the recipient cells as foreign. This is like the opposite of rejection. In rejection, the patient receiving the tissue rejects the tissue. In this case, the tissue is rejecting the body of the recipient. Patients who get graft versus host disease have several different problems in different parts of their body. On the skin, they often get a rash. In the GI tract, they often have inflammation and diarrhea and abdominal pain. And in the liver, they can get elevated liver function tests and increased bilirubin. When you rotate on bone marrow transplants, you will see many patients with graft versus host disease. It's very difficult to get a perfect bone marrow match, and there's often some degree of graft versus host disease, and there are numerous treatments available. Interestingly, a little bit of graft versus host disease is actually a good thing. The new white blood cells in the bone marrow can kill residual cancer cells living in the recipient. This is called a graft versus leukemia effect, and it's associated with increased overall survival and less relapse in patients with some malignancies. So matching for bone marrow transplants is a very complicated operation. You want a good match so that the grafted bone marrow will take in the recipient, but at the same time, a little bit of mismatch is actually okay because it may kill any leukemic cells that are hiding inside the recipient's body. So I'll finish this module by talking about the three different types of rejection of transplanted tissue. The first type is hyperacute, which occurs within minutes. The second type is acute, which occurs in weeks to months. And then the third type is chronic, which occurs in years. And most of the science of this is best understood for kidney transplants. They've been done the most commonly, and they've been done for the longest period of time, so we understand a lot about the different mechanisms by which rejection of transplanted kidneys occurs. Hyperacute rejection occurs within minutes of transplantation. In the case of kidney transplant, it classically occurs while the patient is still on the table right after the surgeon has connected the blood supply to the new organ. And this process is caused by pre-formed antibodies in the recipient. So if you transplant a kidney into a patient and that patient's blood contains antibodies that will attack the kidney, then you will get hyperacute rejection immediately once you connect the blood supply. The antibodies that cause this are antibodies against ABO blood groups or HLA antigens in the donor tissue. Antibodies in the recipient can be formed from previous exposure to foreign antigens. So for example, in women who have been pregnant, they may have been exposed to ABO or HLA antigens from the father. People who have received prior blood transfusions or who have had a previous transplant can all have antibodies in their blood that may attack antigens on the donor tissue immediately as soon as the blood supply is connected. This type of rejection is uncommon and it's prevented by cross-matching, so you test some of the recipient's plasma against cells of the donor to make sure that they don't react. What's going on at a cellular and tissue level in hyperacute rejection is that blood vessels are spasming. This leads to intravascular coagulation, and as a result, the organ develops diffuse ischemia. It's often called white rejection because the organ will be connected to the blood supply, but it will still appear white, and that's because it's not being perfused because there's diffuse coagulation in the blood vessels and there is ischemia. As I said before, this is rare and it's usually not treatable. If this occurs, it usually means the transplant was a failure. Acute rejection is a process that occurs weeks to months after transplant, and this occurs when the recipient's T cells react to the graft via HLA antigens. This is what we try to avoid by good matching. This is a cell-mediated immune response. The CD8 cells are especially important because they will attack the donated tissue cells. If you do a biopsy of patients who are having acute rejection, the hallmark is an infiltration of lymphocytes. And that's easy to remember because this is a T cell mediated process. The T cells are reacting to foreign HLA antigens. And this process is treatable with immunosuppression. In the immunology drug module, I talk about all the different drugs that are used to avoid this process in patients who have received transplanted organs. The final type of rejection is called chronic rejection. This occurs months or years after transplantation, and this occurs to some degree in most transplanted organs. Unfortunately, most transplanted organs do not last indefinitely, and after some number of months or years, they begin to fail from this process of chronic rejection. The hallmark of chronic rejection is fibrosis, especially in the vessels. The effect this will have depends on the organ. In the case of the kidneys, you can see fibrosis of capillaries and glomeruli. In the case of the heart, the fibrosis can lead to narrowing of the coronary arteries. This is called transplant vasculopathy. And in the case of lungs, you can see bronchiolitis obliterans, which means fibrous tissue that obscures the lumen of the bronchioles. This is a complex, incompletely understood process. It involves both the cell-mediated and humoral response systems, and there's lots of research underway to try and understand and prevent chronic rejection because it limits the lifetime many people can get from a transplanted organ. And that concludes our module on transplants.